Hi, my name is James Evan Smith. I'm going to be a senior at Pickerington High School North, and I was in the science internship program this year. The title of my project is The Distribution of Blood Pressure in Response to Quantitative Tilt Testing in POTS Patients. Let's take a look at the background information. When considering the etiologies of syncopal episodes, a form of transient loss of consciousness, abbreviated TLOC, caused by insufficient cerebral perfusion, blood pressure fluctuations are important indices. This study aimed to look at the distribution of blood pressure as indices in patients who present POTS. Patients with postural orthostatic tachycardia syndrome, abbreviated POTS, and autonomic disturbance due to orthostatic intolerance, commonly related to syncope, have elevated heart rates. That is, either 30 beats per minute above baseline mean or exceeding 120 beats per minute sustained. To answer the inevitable question, yes, a patient can present baseline POTS, that is, a heart rate exceeding 120 beats per minute during baseline readings. However, this was not the case for any patients within this study. This increase in heart rate occurs when under orthostatic stress emulated by a head-up tilt test, abbreviated HUT. In other words, orthostatic stress, or the postural tension of being erect, is considered the causality for elevated heart rate. A head-up tilt test is commonly used to diagnose syncope patients. The test utilizes a table that tilts to different degrees while capturing both heart rate and blood pressure readings. In previous literature, POTS patients were defined as having elevated heart rate alone without orthostatic hypotension as a factor. However, clinically, this might not always be the case. Preferential postural beta-1 and beta-2 adrenergic activation could account for an epinephrine-induced increase in heart rate and diastolic orthostatic hypotension, abbreviated DOH, as a result of vasodilation in POTS patients. Now let's break that down before moving on, as it is the theoretical basis for this study. When looking at POTS patients, the sympathetic nervous system could be placing preference on beta-1 and beta-2 transmitter, that is, over alpha neuroreceptors, causing two things to occur. One, preference on beta-1 could be causing a release of epinephrine, ergo the elevated heart rate noted in POTS patients. And two, preference in beta-2 could be causing a decrease in diastolic blood pressure as a result of vasodilation, meaning the broadening of blood vessels. This thought led us to our hypothesis. We hypothesized that POTS patients will prominently present DOH-10. The 10 following DOH will be explained shortly. First, let's look at the methodology. The data includes patients who received tilt tests at the Cleveland Clinic between 5/12/2009 and 9/23/2009. The patient population consisted of 60 patients, 30 who have POTS and 30 who do not. Information regarding each patient's age, gender, and race, and blood pressure distribution based on both traditional and non-traditional quantifiers was captured. In addition to simply testing our hypothesis, we considered the following problem. Postural orthostatic hypotension, abbreviated POH, was previously quantified by drops in blood pressure too great to be presented typically, although it would not be anomalous for this to occur on occasion. As a result, patients who have decreases in blood pressure not great enough to meet the traditional criteria being SOH, a 20 millimeter mercury decrease, and DOH being 10, are not considered to have POH, even if the change in blood pressure was enough to impact the patient's condition. Let's say hypothetically, if a patient were to present a decrease in systolic blood pressure of 19 millimeters mercury decrease, then he, at least in terms of research, would not have SOH. So you see why this is a problem. Thus, we chose to quantify the distribution of blood pressure during HUT as mild, moderate, and marked POH to better illustrate the degree of intensity while still referring to traditional quantifiers as the primary source. The following quantifiers were established. DOH-5 for moderate and DOH-10 for marked, and then mild, moderate, and marked for SOH at 10, 15, and 20. You will note that there isn't a mild DOH because any fluctuations from 1 to 4 would be too minute to be considered significant. For example, to explain, DOH-5 represents a series of 5 blood pressure readings starting at time t of HUT, where both 1, the reading at time t is 5 millimeter mercury below the baseline mean, and 2, the average of the remaining readings is also 5 millimeters of mercury below the baseline mean. Both would have to be true to be considered DOH-5. This definition was applied to all categories of POH. In terms of statistics, differences in the frequency of blood pressure distribution between POTS patients in the control group were evaluated using Pearson's chi-squared test. The appropriate level of significance was selected for each test based on its degree of freedom. All statistical tests assumed a 0.05 significance level. Looking at the demographics now, we can see that females are dominant in this particular population. However, this does not deviate much between POTS patients and the control group. 90% females in the POTS group and 73% in the control group. In terms of mean age, also not much deviation, although there is some. POTS patients tended to be slightly younger. Finally, in terms of ethnicity, the cohort was preponderantly Caucasian, with small proportions being Asian and African American. Let's look at the data. Figure 2 illustrates the difference in frequency of DOH-10 between POTS patients in the control group. This chi-squared test assumed a 0.05 significance level with 1 degree of freedom, as there were 4 categories. The resulting p-value of 0.03 shows that the DOH-10 is preponderant in the POTS population, confirming our hypothesis and disproving our null. Figure 3 depicts the differing distribution of blood pressure response when considering exclusivity. Notably, 0% of the POTS population presented SOH without DOH. Maybe some dependence on the two. Moreover, only 20% of POTS patients had no form of POH. This validates the presence of POH in the POTS population. Table 2 identifies instances of POH at varying intensities. Notably, there is no particular difference in SOH between the POTS population and the control. However, there is an anomaly when considering occurrences at different intensities of SOH. Moderate SOH presented minutely, while mild and marked SOH accounted for a greater portion of the entire cohort. In terms of discussion, DOH-10 proved to be significantly more preponderant than POTS patients. This disproved our null hypothesis. Previously, POTS patients were defined as having elevated heart rate alone without orthostatic hypotension as a factor. The results of this study should help to stimulate debate in that regard. Only 20% of POTS patients presented no form of POH. DOH-10 was most prevalent. The underlying pathophysiology of this phenomenon may be preferential activation of beta-adrenergic receptors over alpha by the sympathetic nervous system in response to postural stress, resulting in a catecholamine-induced increase in heart rate and a concomitant drop in diastolic blood pressure from vasodilation. To conclude, POTS patients typically have POH as a cofactor, primarily DOH-10, to elevated heart rate. Preference on beta-1 and beta-2 receptors over alpha receptors should be considered for causality. Clinically, this means that physicians could prescribe medications for this patient population differently as the distribution of blood pressure differs. And we must remember that POTS and POH are manageable through treatment. Even non-pharmacological treatment exists, for example, physical therapy, lifestyle and diet modifications, etc., for patients who are concerned about prolonged pharmacological treatment. Finally, I would like to thank my mentor, Dr. Fuad, for all the help that she gave me this year. Also, Dr. Wiedis and Dr. Franco for their assistance and support. And then finally, the Cleveland Clinic Office of Civic Education Initiatives for making this opportunity possible for me. Thank you.